So this is going to be a session on wound pain assessment and management. My name is Lauren Corcoran. I'm one of the senior tissue viability nurses. Just as a bit of background, obviously this is meant to be pain management focused on when we're managing wounds at the same time. It's a piece of work I did when I've not long been with the team. Felt quite strongly about it. I was recognising that a lot of patients are having pain associated with their wounds, and I just felt that our assessment of it and the considerations were quite restricted. More looking at a generalised pain, and I wanted to really kind of get some specifics down in terms of how we manage that when it's wound pain, but also looking into what we can ask about the pain and how we can make our assessment of their pain more valuable and the treatments for it. So yeah, this is a short session on wound pain assessment and management. So just to begin, what is pain? And the definition of pain is that is an unpleasant sensation felt as a result of the brain's response to disease or damage to the body. And that's Brown 2014. And what are the types of pain? So there are actually two main types of pain. They are nociceptive and neuropathic pain. So the differences between them, nociceptive is usually arising from the direct damage to tissue. So what happens in this instance is that signals are picked up by the sensory receptors, which are then transmitted to the spinal cord and then the brain, and that's when we interpret them as pain. So that's our kind of day-to-day normal pain as such. Whereas a neuropathic pain is a pain that's caused by damage to or dysfunction of the nervous system, and it causes an abnormally strong response. So it's very important to determine what type of pain the patient is experiencing, as they require different treatments. So in that, we want to make sure that we manage that patient's pain to the best of our ability, and we're not going to be able to do that unless we know what pain they're experiencing. One thing to note, if you're seeing a patient for the first time, or perhaps you've been seeing them for a while, everyone needs to consider that any new or an unexpected or change in pain could be a sign of wound infection, or it could be a sign of ischemia. So it's very important to consider those things as well if you've never met them before, or if you've known them for a long time and their pain is quite new, or it's a sudden change. Think about what else could be going on in the background. Okay, so things that will allow us to recognise whether it's the nociceptive or the neuropathic pain that they may be experiencing, different kind of characteristics of each. So the nociceptive, the more normal pain, it can be described as nagging, throbbing, gnawing, usually due to direct tissue damage or ischemia, as I said, caused by inflammatory markers that occur on injury and may be due to prolonged healing time. Neuropathic pain, on the other hand, is got a different sensation. It's usually described as prickling, tingling, pins and needles, stabbing or shooting. The skin or wound may be abnormally sensitive to touch. Like I said, with that definition, it's a real heightened pain. And it may come on in sudden bursts for no apparent reason. The temperature may deem to have changed, so they may describe it as hot or burning. Okay, so when we are thinking about our pain assessment, our patient tells us they have pain. What should we be asking? Because often we do ask them, do they have pain, and they're able to say yes or no. And I sort of feel like the assessment, doesn't progress as much from there, and automatically we're thinking, okay, well, they have pain, and what are we going to do to treat that? But there are some key things that's really good to discuss more in depth about their pain, so that we can try and manage that better. And the way to do that is using the acronym OLD-CART. So if people are good at remembering things this way, then OLD-CART, basically standing for the onset or the cause, the location of the pain, and it's really important to note that pain over pressure points would indicate the first sign of damage. So going back to what I was saying before, if you've got a patient you may know quite well, or perhaps a new patient, but this pain is really heightened, or it's odd and it's come on all of a sudden, think about what else is going on. Is it wound infection? Is it ischemia? But also consider the fact that if it is located over a pressure point, it could indicate that they have got the first sign of pressure damage. So going back to the old cart, then we've got D is for duration, characteristics of the pain, any aggravating and relieving factors. So there are certain things that make it worse or better, particularly in ischemia. Often because they've got poor arterial flow to their leg, they'll find that elevation of their leg is more painful, solely because then the arterial flow is more difficult. Whereas they will say that then hanging their leg out of bed, for instance, or putting their legs down actually helps to relieve the pain. So it's just picking up on those little things to make you think what actually could be the source of the pain. Any treatments that they're currently taking. So we get these lovely people that we speak to, they say that they're in absolute agony, and when you discuss with them, you actually realise that they're not actually taking any current treatment, or perhaps they're not taking their current treatment correctly. So it's those small things that we can pick up on to hopefully manage their pain better. And what is the impact of the pain on the patient's quality of life? So actually it may be that this is having a huge impact on their quality of life, which in turn is having an impact on the interventions that we're able to make, especially in regards to wound care. We get a lot of referrals of patients who may be deemed sort of non-concordant as such. They may be really just struggling with their pain, and that's actually their top priority, to be able to get on top of that so that they can accept the treatments that we're able to give. It's just a lot of coaching and reassurance as well. As you know, often if there are wound infection, if there is a huge amount of edema on board, treatments like antimicrobials, compression, they are all things that should then in turn actually minimize that pain, because it's getting on top of the underlying cause. But it's really trying to explain that to our patients and help them to understand that, because pain can have a huge impact on their mental health and their quality of life. So if that is the case, and if this is their main concern, we really need to make it our priority. Okay, and what about those who we can't have these sort of discussions with, who maybe can't express their pain so well? It may be patients with a very severe dementia, etc., who aren't able to verbalise and communicate that. So important things to do are observing non-verbal cues. So if you're doing the dressing, they're grimacing, they're guarding the area, or they've got restricted movement, and discussing with family and carers as well. These are people that may spend a lot of time with that patient, and they know them more than better than anyone. And maybe it's worth trying to have that discussion with them, and they should be able to kind of give you more information. Okay, and so with pain, the type and intensity of wound pain experienced by patients is influenced by both physical and psychological factors. So it sounds maybe obvious, but patients' pain it's such a cliche thing to say, but it is what they say it is. Every patient is different. The same group of patients could have the same pain inflicted upon them. They could all have different responses to that. And there are factors that influence that, so just be aware. Physical factors such as the cause, the site and the symptoms of the wound, any wound debridement we're trying to undertake, poor dressing techniques or use of inappropriate dressings. And I am going to be going into more detail about these kind of wound management considerations on a later slide, but it is important to consider what else is impacting, and maybe what things we can do to then minimize that if there is a physical factor kind of taking hold. Psychological factors as well. If you've got a patient who's already quite anxious, they're stressed or they're fearful, or they've got mental health problems, low in mood, these may also cause sleep disturbances, which then will further reduce their pain tolerance. And actually just then kind of having that fear and that anxiety or that low mood in regards to their wound, sometimes they're almost preempting the pain, and it makes it so much more heightened. So these are all just things to consider when we're looking after our patients. So coming on to pain management, when we've been able to assess and take into consideration what factors maybe influencing the pain, and we've asked them detailed kind of questions about the pain. It's thinking about how best to manage it. So I did start with non-pharmacological therapies purely because I was also noticing, you know, when I first started this piece of work and became interested in it, that we're always jumping to a pharmacological method of management. And, you know, a lot of patients, rightly or wrongly, they don't want to be on lots of pain relief. Certain medications make them feel drowsy, make them nauseous, or simply they just don't want to be reliant on that medication. So I'm not saying it's not right. Obviously, we will be exploring the pharmacological methods as well, but rather than just jumping to that, and you know, often we will speak to the GP, the doctor, and say they're still having pain, and often pain medications just get increased. It's just really thinking about what other methods we can use to help with that pain management when we go and deliver care. So reducing anxiety, so talking to the patient, tell them what you're about to do, and what you're going to do to minimise the pain as well. Like I said previously, often they're preempting that pain before you started that care. Maybe they knew it was painful before. Generally it's painful, so they're very anxious about you doing the wound care, touching the leg, touching the limb. So just take the time to explain to them what you're doing and how you're going to help, and that should reduce their anxiety, and in turn then help them to be sort of calmer and tolerate a lot better. Distraction therapy is a good one as well. Often if we are distracted by something, we're not focusing on the pain and it is not as painful. So something simple that they enjoy, maybe while you're doing the dressing, they could be watching television or listening to music, even just chatting to you. I know it's difficult when you're trying to focus on a task, but trying to keep them talking as best as you can, or maybe another activity that they like doing, you know, knitting, anything. This will help them to switch their focus, and hopefully then they're not just concentrating on the pain. Aromatherapy, maybe not quite as possible, but if they're, you know, even if they're in their own home and there's candles and things that they like to burn, but particularly essential oils in aromatherapy can produce a sense of relaxation or may stimulate positive memories and feelings. Another interesting thing that one of my colleagues had done previously in terms of, you know, talking about stimulating positive memories and feelings, she did ask the patient to kind of discuss with her and envisage that place where she felt most positive, or a place that made her feel happy and calm, or thinking about other, you know, previous memories that made her feel happy and relaxed and calm, and just asking your patient to take themselves back to that place, and discussing that can really help. Again, it sounds very cliche, but it does really work. She saw a lady who was in horrible, incredible amount of pain with her legs, and while doing the dressings was encouraging her to kind of take herself to another place. And it, you know, by no means did it stop her pain entirely, but it did really help her get through that dressing change. Okay, so the pharmacological methods, the appropriate use of analgesia both alone and in combination is key to minimising wound pain. So as we'd all be aware of, the analgesic ladder, so it's looking at using opioids in combination sometimes, so basically just stepping up depending on their pain. Like I've said, there's no wrong in this being part of their management, but I did just really want to encourage the fact that we don't always need to just jump straight to pharmacological, and just take the time to look at other methods as well. But certainly, yes, when their pain is severe, it's taking the time to think about what pain relief they're taking. Are they taking it correctly? Are they taking it in combination with something else? And just, you know, making sure of that. I've got patients who are in a lot of pain, but they'll only take paracetamol as and when. Now, with paracetamol, it's quite important, if for that period that you're in pain, to be taking it regularly, just to build up your pain threshold and just stop all the peaks and troughs in the pain relief. And just something as simple as that makes a huge difference then to how their pain is then managed. So, you know, just key things. And also, you know, if they're taking it when they're really in pain that's unbearable, the paracetamol then does take time to provide that pain relief. So, you know, if you've if they're taking it when you're already starting to do the dressing because it's painful, it's then going to take a while for them to get that therapeutic effect, by which time you would have then done the dressing and they probably haven't actually experienced the pain relief at the time that they needed it. Okay, then neuropathic pain. So there's, you know, the analgesic ladder, more so for our nociceptive pain, and actually neuropathic pain. The reason I say that it's so important to determine the difference between the pain that the patient is experiencing is because neuropathic pain can be treated differently. So it may respond to opioid analgesics, but generally it should be managed with a tricyclic antidepressant or certain anti-epileptic drugs. So examples of these are amitriptyline, pregabalin, and gabapentin. Those are the ones that are commonly used. Obviously, all of these things, both the analgesics and these medications for neuropathic pain, would need to be discussed with a GP. All medications, you know, in themselves, there's going to be side effects, pros and cons. You know, it's about having that conversation, about the patient being aware, the GP being aware, and having what's appropriate for them. For instance, amitriptyline, people can get quite drowsy, so they tend to prefer that it's taken at night rather than during the day, etc. So all of those things to consider, but that's why it's really important when you're doing your assessment to think about if it is more of a neuropathic element to their pain, because actually they may be on lots of opioids that don't seem to be managing it, but maybe that's because they need to step back on the opioids and actually try a different drug to help with that neuropathic pain. Okay, so things that we can do ourselves. So we've looked a bit at, you know, our non-pharmacological methods, pharmacological, but as clinicians, what we can do when we're actually dressing that wound, I will list and talk about here. So infection management. So we would say we need to treat that promptly, and you can use our AMBLE tool for guidance. So anyone that doesn't know the AMBLE tool, it stands for Assessment and Management of Bacterial Load in Wounds. That is available on our website, but it's essentially like a traffic light system document. And it lists sort of signs and symptoms and what's going on with the wound, and makes us think about whether we think that this wound may be sort of heavily colonized or infected, and whether we need to start some treatment for that. Wound infection can be incredibly painful for patients, so untreated, that is going to be a huge contribution to their pain. So keeping an eye out, being able to assess and recognize wound infection and then treat that with antimicrobial dressings is key. Another one is dressing trauma. So dressings can cause trauma to the wound bed if they adhere or dry out. And that can be incredibly painful then for the patient when you're coming to remove them. So it's trying to get that balance right. One, looking at your wound bed and thinking about what's appropriate and getting that balance of moisture right. So if you've got very dry wound bed, we don't then want to be sort of getting things stuck even further. So you know, thinking about that, or you know, if we're using certain dressings and do we need to think about things like adhesive remover sprays to aid comfort? Do we need to think about, you know, lots of soaking off of the dressings and that being clear in the management plan? You know, because all dressings to a certain point, you know, you need to, they're not just going to drop off as you take the dressings off. I mean, sometimes they do if the leg or the wound is extremely wet, but it's just kind of having that consideration really when you're trying to get that primary dressing off. Is it clear in the care plan that it needs soaking, etc.? Exudate, so kind of links in, but exudate should be managed with appropriate absorbent products, and a skin barrier product may also be required. So kind of we talked about drying out, but going the other way, high levels of exudate that go unmanaged can be incredibly painful. It's basically like acid sitting on the skin essentially, and it just strips away that skin. And I'm sure lots of you have seen the skin, you know, it can become macerated or also can get very excoriated and sore. So trying to manage that exudate the best that you can is really important, and also thinking about, do they need a skin barrier product for a period of time just to try and recover that skin and protect it from the exudate. Cleansing is actually reported as one of the most painful experiences associated with wounds, but as we know, it needs to be done. The wounds do need to be cleaned, but cold water has been reported to increase pain, whereas warm water will help maintain blood flow to the wound bed. So just something as simple as trying to make sure that you are using a nice temperature of water, you're not using really cold water when we're cleansing. Compression therapy, so it's fab, but unfortunately, if it's not applied correctly by someone that's had adequate training, you can do more damage. So you can cause ridges, pockets of edema, and unfortunately sometimes open wounds if you're not carrying this out correctly. So I'd urge anyone who is applying compression, make sure they have adequate training and they feel confident with what they're doing, and when we're not just exacerbating things. And then the last thing we need as well is them to get issues off the back of poor compression application, and then down the line they then refuse that compression because they've associated that with other issues, and then we're in a bit of a sticky situation, because actually the compression that they need to help with their wound, their leg ulcer, is then not possible to apply because the patient doesn't want it. So it's thinking about what we do every step of the way. Ischemia as well. Ischemic legs are can be very painful for patients due to the arterial insufficiency. So if you have got a patient that's got clinical signs of ischemia, they do need an urgent referral to vascular. It may be that you are suspecting some arterial disease, and this to be investigated further, and that may well be a routine referral to vascular. But someone who's got a quite clear, obvious ischemic leg, or that you're suspecting, we would say do that urgent referral to vascular. Okay, so that comes to the end of the presentation of wound pain assessment and management. So hopefully those things there give everyone kind of a bit of an idea of when they are assessing, the kind of things to be asking, keeping in the back of their mind, but also things that we can do as clinicians to try and minimise that pain as best as we can, and not always just jumping to pharmacological management and having patients on lots of different opioids. Okay, many thanks everyone for joining in on the session, and hopefully I'll see you soon.